So today we are going to have a brief discussion on lymphomas, PETCT in lymphoma especially. So these lymphomas are heterogeneous neoplasms of hematological malignancy affecting mainly the lymphatic system and the extra lymphatic systems. There are various types of lymphomas, especially B cell or T cell or non-Hodgkin's, etc. And the staging is also is very important in the lymphomas. Lymphomas are especially confined to a single group of lymph nodes, or it may be complicated to spread into other extra lymphatic systems, where like CNS, spinal cord involvement, etc. So, treating a disease, treating a lymphoma is very important in a clinical setting. And before treating these lymphomas, the diagnosis of the lymphomas is very important. And in the present medical scenario, with the various the imaging modalities like CT scan, MRI, PET-CT. So, which modality has to be taken? Which modality has to be prescribed by the clinician, either in the upfront imaging or in the follow-up imaging? That we will briefly discuss in this session. So, to continue this discussion, we have two eminent faculties. One is Dr. Nadeem Ahmed. He is a medical oncologist. He is a consultant medical oncologist and hemato-oncologist working in Mythri Hospital. Welcome, sir.
Hello,
Sir
hi
has
everyone.
been from Dakhan Medical College, Hyderabad, and he has completed a MD Radiation Oncology from prestigious NIMS, Hyderabad. And he has also completed he's done his DM Medical Oncology from the prestigious Adayar Cancer Institute, Chennai. He has a lot of certification courses in palliative care as well as in methodology, as well as he's a member of ESMO. Sir is actually has done various publications, as well as he has done 21 hematopoietic stem cell transplants for both adult as well as the pediatric patients. He has involved in one CRT BCMA therapy for relapsed multiple myeloma. Welcome you, sir.
Hello. Hi.
One more speaker from our faculty, Vijaya Diagnostic Center, Dr. Saikrishna. He is a consultant nuclear medicine. He is going to speak on PET-CT today. Sai Krishna is done is sorry. Sai Krishna has done his MBBS from SWIMS Medical College, Tirupati. He has done his MD Nuclear Medicine from SWIMS. He is an RSO certified officer, and he has various publications as well as case reports. Welcome, both of you. Sir, Dr. Nadeem Ahmed, sir, just a brief introduction regarding clinical aspect regarding PET-CT in lymphomas. Over to you, sir.
Yeah. Hello everyone. Hope
Yes,
I am audible.
yes, sir. Yes.
So now, from a medical oncology point of view, as we all know, for lymphomas, PET scan is the most important thing for Hodgkin's and non-Hodgkin's lymphoma. I'll briefly tell about Hodgkin's lymphoma, how we use PET scan. You guys already must be aware, but still, one is that in early stage and both at early and advanced stage for diagnostic workup, PET scan is absolutely necessary for two reasons. One is to know the to assess the response, and third, which is often forgotten, is also for radiation. Like for example, if you are planning PET-based radiation therapy, then the patient has to undergo PET scan in the treatment position upfront. This is more applicable in early stage Hodgkin's, which we have to keep in mind whenever we are advising. Then the second thing is, after, let's say if it is early stage or advanced stage, initial regimen that we follow in DR Cancer Institute, now in MNJ Cancer Hospital, also in Mythri, is to give 2 cycles ABVD upfront, followed by PET scan, interim PET. Based on interim PET, we will de-escalate. In early stage favorable, we will, if the D score is between 1 to 3, then we will give one more cycle of ABVD and RT. If it is unfavorable, then 2 more cycles ABVD and RT. And whereas in advanced stages, we will, based on if it is D score 1 and 3, then we will proceed with 4 cycles AVD. We will remove the bleomycin because of cumulative lung toxicity. But if it is positive, if it is 3 or 5, it is 4 or 5 D score, then we'll do a biopsy, preferably, And then we'll proceed with BioCop or escalated BioCop based on patient's performance status. It is quite an intensive regimen, so we need to be absolutely sure about the PET imaging, whether it has progressed, activity, size, everything. We have to discuss with the nuclear medicine physician in detail. Then only we can take a call, preferably in a tumor board, not individually. Then, so this is for Hodgkin's lymphoma. Hodgkin's lymphoma, as we all know, bulky disease. I think sir will be discussing better. Is more than 77.5 centimeter. And if at the end of induction PET scan, if it is showing, if initial PET scan had a bulky disease, then we'll irradiate the initial sites. And if there is no bulky disease initial, but residual disease is more than 3.5, 2.5 centimeter with activity, then we'll irradiate that also. If it is not active, then we will discuss with the criminal physician and other colleagues and take a call. So this is briefly about Hodgkin's lymphoma. Also, in interim PET, we can do 2 days prior to the next cycle. We need not wait for 4 weeks as we traditionally do for PET scans. Like for example, chemo, we wait for 4 weeks. Radiation, we wait for 12 weeks to get a PET scan to see the response. But if it is interim PET, then we need not wait for that much. There is another IP interim PET also. Like example, if we give 2 ABBD, if D score is not 3, not less than 3, we give BioCop, and then we do another PET that is known as interim PET 2 basically. So going on from Hodgkin's to non-Hodgkin's PET scan is also very important for evaluation and response assessment, but there is no de-escalation strategy based on interim PET. So we still do interim PET in non-Hodgkin's lymphomas, but that is for seeing the disease status, not to change the treatment as such. Because if it is clinically progressing, then what I mean to say is, like in Hodgkin's, you make ABBD to AVD, you remove bleomycin, or you make ABBD to BioCop or escalated BioCop. That you don't do in non-Hodgkin's lymphoma, like Hodgkin's. So there is no de-escalation. Also, one more point which sir must be discussing is in the staging workup also. For staging Hodgkin's lymphoma and non-Hodgkin's lymphoma, we both use Ann Arbor staging. But in non-Hodgkin's lymphoma, all this Walde's ring, spleen, everything is extranodal. Whereas is nodal, whereas in Hodgkin's lymphoma it is extranodal. If I'm remembering it correctly. I don't think we should go too much into trials. There are many trials. There are German trials, and then Rapido trial, which is giving 3 cycles ABBD upfront, and with the addition of most recent drug, that is brentuximab, the standard ABBD has been changed now to, not in all settings. I have not personally used for more than a couple of patients. You remove bleomycin and you add brentuximab vedotin. So it is A plus ABD in place of ABBD. That is most recent update. Apart from that, over to you, sir. If any questions or anything I can help, then feel free.
Hi, sir. Good evening. Today I will be discussing briefly about PET-CT in lymphoma. Am I audible, sir?
Yes.
So this would be the outline of the topic: lymphoma types and clinical presentation, staging systems, PET-CT, where does it play a role, staging, post-therapy assessment, relapse or recurrence, and RT planning, and what are the difficulties we face while interpreting, that is image artifacts as well as pitfalls, and which are the close differentials for lymphoma as well as. And to summarize, we'll have a slide. So, as Sir told, these are a group of hematological malignancies derived from lymphocytes or blasts. Predominantly, they occur in lymph nodes. At times, we can see extranodal disease also. So, usually the incidence is approximately 4%, but in children, it is up to 10 to 15%. Majorly, broadly classified as Hodgkin's and non-Hodgkin's, but disease. So, clinical presentation, as I said, nodal. But if it is an extranodal disease, it can affect any organ, and it can normally when it is Hodgkin's or low-grade NHL or indolent NHL, they usually present with lymph node involvement alone. But if it is an aggressive NHL, they can present with extranodal involvement or contiguous involvement, which have mass effect like that. And obviously, in lymphoma, we have a B symptoms, patients present with fever, night sweats, and weight loss. So WHO has given varied classification, but the major division being Hodgkin's NHL, 40% being Hodgkin's, 60% NHL, and mature B cell, mature T cell lymphomas and post-transplant lymphoproliferative disorders are also there. And to say majority of the lymphomas are B cell, which constitutes 85%, and the remainder being T cell. So diagnosis is very challenging, and it is integration of morphological either by lymph node biopsy or bone marrow biopsy, whatever it is, followed by IHC and cytogenetics. And many lymphomas, either it is Hodgkin's or non, they have a characteristic morphological patterns on biopsy. So it is better to have a excision biopsy rather than core biopsy or an FNSC. It is, I mean, difficult for a pathologist to diagnose a lymphoma with FNSC. So then comes the staging system in lymphoma. So there are, two staging systems: Ann Arbor, which was previously used, then now Lugano. So based on the involvement of lymph nodal stations, broadly classified into 4 stages. Stage 1 is involvement of single lymph node or single extra lymphatic sites on one side of the diaphragm, and stage 2 is more than lymph node regions with or without involvement of extra lymphatic site, as shown. And stage 3 is on both sides of the diaphragm with or without the involvement of spleen. And stage 4 is multiple or disseminated disease. These are few examples which I am quoting here. See, isolated involvement of right cervical lymph node without any disease. This becomes stage 1. You can see both side cervical lymph nodes with mediastinal lymph nodes. Only above the diaphragm, stage 2. Above below diaphragm with involvement of spleen, stage 3. And disseminated disease with bone and spleen involvement above below diaphragm nodes, stage 4. See, there was some modification by Costwall. He added some suffixes for this. So B suffix mean B symptoms that I said already: fever, weight loss, and night sweats. I mean, A means absence of these symptoms. X is for bulky disease, more than 10 centimeters or one-third of the intrathoracic diameter. E is extranodal extension, that is contiguous, and S is splenic involvement. So this extranodal contiguous extension has to be fit within the radiation field. If it is more extensive than that, it can be considered as stage 4. And tonsils, Valdersing, and spleen are nodal tissues. They're not extranodal sites. So coming to Lugano classification, broadly classified as limited disease and advanced, where 1, 2 of Ann Arbor will come into limited disease, whereas 3, 4 will come into advanced disease. And Lugano modification has omitted A and B symptoms. They have applied only for Hodgkin's lymphoma, and they have omitted this X bulky disease and asked us to mention the largest nodal diameter. See, now comes the role of FDG PETCT in lymphoma. See, majority of the lymphomas are FDG avid. There are few lymphomas which are non-FDG avid or low FDG avid. Hodgkin's, predominantly all of the Hodgkin's lymphomas are high FDG avid. DLB, CVL, extranodal T cell lymphomas and peripheral T cell lymphomas are high FDG avid, whereas follicular, CLL, SLL, marginal zone or maltomas are generally low or variable FDG avid. So routine use of FDG is useful in all FDG avid lymphomas, and at times they can identify the sites of low grade to high grade transformation, that is richest transformation, and they can guide the site for biopsy. So in initial staging, what we see generally is nodal stations involved as above below diaphragm, and that is preferably used for staging, and identification of extranodal site involvement, any cord involvement or like that, and presence of bulky disease or largest node. I mean, later on it can have a role of RT, and presentation itself is an extranodal lymphoma. So just to have a few slides about the presentation. This is a typical presentation of Hodgkin's, usually supradiaphragmatic in nature. 60 to 70% of times it involves cervical, 30% mediastinal axillary. Initial presentation, extranodal presentation is seen at 10% of cases, most common being bone marrow, bone, liver, and lung. And in the initial staging of Hodgkin's lymphoma, we expect 10% or 10 to 15% of upstaging. These upstagings preferably are seen as a normal sized lymph nodes which show FDG uptake, or as a focal bone marrow uptake, which awaits bone marrow biopsy in HL also. So this is just to show a bone lesion which is typically FDG avid, intense FDG avid, and CT wise it is normal. So initially presented with the right supraclavicular lymphadenopathy. When we did a PET-CT scan, it is showing as a disseminated disease, above below diaphragm nodes, splenic, and even bone involvement as seen in the sternum. So the other pattern is a follicular lymphoma, which is a second most type of NHL. So it is generally low grade, presents with generalized lymphadenopathy, cervical, in axillary, at times inguinal and femoral also. Extranodal involvement is also seen at initial presentation, and these are generally low grade lymphomas. And doing this, we can identify FDG. Doing in these cases, we can identify the transformation, if at all. So this is a typical case with generalized lymphadenopathy and splenomegaly, but we can see diffuse marrow uptake in this case. DLBCL, typically enlarged nodes are seen, high-grade malignancy. 40% of the times it is on one side of the diaphragm, but in 20% we can see on both sides, and another 40% we can see a widespread extensive disease. So it can also present, DLBCL can also present as primary extranodal lymphomas, most common being GIT. We have seen many cases of kidneys, testes, etc. And the typical sites of extranodal spread are bone marrow, liver, and lungs. And in this setting of DLBCL, FDG PET-CT, even if bone marrow, uptake is negative, we still need to consider for a bone marrow biopsy, because the chance of marrow involvement is very high in DLBCL. This is just to show how extensive a DLBCL can be seen, almost involving all the bone and bone marrow. So PET-CT is also used for extranodal lymphomas, preferably gastrointestinal. With high sensitivity, it can be used both for initial staging as well as response evaluation. So avid tumors are preferably used in FDG is used for avid lymphomas, most commonly maltoma, external marginal zone lymphoma, lymphomas of orbit, parotid, and thyroid. We had one case of this orbital maltoma. So when we did PET-CT, we found this small lung involvement also, nodule in the right lung. So what is the role of FDG, PET-CT, and bone marrow uptake? To differentiate between Hodgkin's and non-Hodgkin's. Hodgkin's lymphoma, diffuse bone marrow uptake is usually seen, but bone marrow is uncommon in limited stage of Hodgkin's lymphoma. When it is a focal bone marrow uptake, it has to be taken as PET defined bone marrow involvement, and no uptake is negative for bone marrow involvement, which evades bone marrow biopsy. That means in Hodgkin's lymphoma, it has a very high negative predictive value. Whereas in NHL, diffuse bone marrow uptake should be considered for a bone marrow biopsy, and focal uptake is anyway taken as a PET defined involvement. And bone marrow uptake, as said, is more common in NHL than HL. So, but what emphasizes here is in indolent lymphomas and in DLBCL, where FDG uptake is even if FDG uptake is low in bone marrow, still it has to be considered for a biopsy. So this is to summarize. Bone marrow is not needed if negative PET-CT in especially Hodgkin's disease, and diffuse homogeneous non-specific uptake in Hodgkin's disease. Focal uptakes in HL and NHL, bone marrow is not needed because it itself confirms as a bone marrow involvement. And bone marrow may be needed in NHL if it is a low grade or indolent or diffuse bone marrow uptake in NHL. And even if negative PET-CT in DLBCL, we need to look for a bone marrow biopsy. So because it is a high risk, it is the involvement of bone marrow indicates a high risk, and it has been seen in 10% of newly diagnosed HL and 25% in NHL. The other thing where FDG PET-CT is used is for response assessment. So we have this De Villers score, where it is a visual interpretation score. Score 1 is no FDG uptake. Score 2 is uptake less than mediastinal blood pool, and score 3 is more than mediastinal blood pool, but it is less than liver. And score 4 is uptake more than liver, and score 5 is markedly more than, that is 2 to 3 times more than that of hepatic activity. So when do we see this De Villers score? Where is it useful is in almost all HLs, and avid NHLs like DLBCL and Moldion. Not recommended in low-grade lymphomas as such, CLL, SLL, like that. So this is just to show how the uptake scores will be categorized. You can see here left level 3 cervical lymph node, where it is more than blood pool but less than liver activity. So this has been labeled as 3, and this is more than liver, right supraclavicular lymphadenopathy, so labeled as 4, and intense FDG ability seen in the abdominal nodes. So intense than hepatic activity is DVLA 5. So The other criteria is Lugano. Lugano also uses DVLA 5-point score to categorize patients as complete metabolic response, partial response, stable disease, and progressive disease. So the comparison is between baseline and interim PET as well as the post end of treatment PET. So as said, preferably it should be done 6 to 8 weeks after chemotherapy or just before the next cycle of a chemotherapy, and 2 weeks after GMCSF treatment and 3 months after radiotherapy. So, in using this score, we can categorize as complete, partial response, stable disease, and progressive disease. So, DVLA score 1 and 2 and 3, even 3 can be considered as complete response if a patient is undergoing a standard treatment. 3 is a gray zone when you are opting for a de-escalation cutoff. So for a de-escalation cutoff, 1 and 2 should be taken as a complete response. And score 4 and 5 and the FDG uptake is decreasing from the baseline and no other new lesions. So this indicates a responding disease. And score 4 and 5, stable uptake from the baseline. And so it is considered to be as a no metabolic response, NMR. And score 4 and 5, but with increased FDG uptake from the baseline and new FDG avid lesions, so they can be considered as a progressive disease. So to summarize this, residual masses can be seen in mediastinum and they remain on CT in HL and NHL also, and at times they represent fibrosis and necrosis and sometimes active tumor also. It has to be correlated well with that of a FDG uptake. So that is how 1, 2 is considered as complete metabolic response at interim PET and as well as at end of PET. Score 3, as I said, depends on interpretation. Either good response when it is continued as a standard therapy, or when it is de-escalated, it can be considered as underrate. 4 and 5 at interim reduction from the baseline suggest chemosensitive disease, and 4 and 5 at the end of treatment suggest treatment failure. Just to show one case of partial metabolic response, we can see intense FDG avidity in abdominal and retroperitoneal nodes, which after end of the treatment, interim assessment, we can see mild FDG avidity, which is more than liver. So it is categorized as DVLF4. So it has been labeled as PMR, partial metabolic response. This is a DLBCL case with extensive disease. After end of PET-CT, we can see beautiful response. So complete metabolic response. This is end of treatment response evaluation. So I did in a case of suspected relapse, case of follicular lymphoma after end of treatment assessment. This was labeled as complete metabolic response. Then patient presented with right supraclavicular swelling. Then we did a PET-CT. So we have seen some nodal mass here. So it was categorized as relapse. But routinely, FDG is not recommended in surveillance because many cases false positivities can be seen. So the other entity is immunomodulator therapy, who are refractory to conventional chemotherapy, or now recent modifications they have been adding immunotherapy. So what happens is in immunotherapy there will be immune-mediated response which cause flare up in FDG uptake that we call as metabolic flare or pseudo progression. So in this setting, we label some patients as indeterminate response. So this is a case where Hodgkin's lymphoma, where initial scan it is shown as right supraclavicular lymphadenopathy and mediastinal lymphoma, where after 4 cycles of pembrolizumab, we can see that there is a flare up of these lesions, and at end of the treatment, follow-up scan shows a negative. So initially, in between, it has been categorized as intermediate response. So in this intermediate response also, we have criteria whether it is more than 50% increase in the size or less than 50% increase in the size, or just FDG uptake without any increase in the size. So IR1 and 2 needs a biopsy confirmation, whereas IR3 is typically immune mediated as shown in this case, and we can wait for follow-up scan in this case. So the other thing is FDG PET-CT and RT planning. As are told, involved node or involved site RT can be given, limited stage HL and NHL. So pre-treatment FDG PET-CT images are mandatory, that too in the position of RT treatment. So post chemo planning CT will be done, and it will be co-registered. So what advantage we have is better target volume delineation. Involved node can be done only if pre-treatment PET-CT images are available. Involved site can be done without PET-CT also. So Next, coming to the artifacts and pitfalls when we find it difficult to differentiate node versus physiological or varied uptake. So this we can see bilateral supraclavicular uptake in this patient. So without any CT morphological abnormality, this is typically a brown fat uptake. Normally we see in these lymphoma patients, and we can see this paraspinal activity. So everything is related to brown fat uptake. Symmetry is, symmetry is to be seen while reporting for a brown fat uptake. So the other case is here a small uptake in the mediastinum. Initially, it was thought to be a small node. Then on the follow-up scan also it persisted. So it later revealed it as an atrial appendage. So atrial appendage will have an FDG uptake, should not be confused with a lymph node involvement. This is MBBS showing diffuse bone marrow uptake after chemotherapy. This is reactive bone marrow. Patient had GM-CSF induced. This is a reactive thymic hyperplasia, and this is ground glass opacities. So we have to watch for a coexisting infective etiology also. So the other thing is close differentials while diagnosing lymphoma or mimics on FDG PET-CT. So we have a commonly see about TB, sarcoid, and Castleman's disease. So these are some of the cases with extensive tubercular involvement. Typically presents as above below diaphragm nodes only with splenic involvement. So after ATT, it has a good response. This is also a case of Castleman's disease. We can see, above below diaphragm nodes and splenic involvement. The same, especially in this sarcoid case, we can see, more, focus concentrated lymph nodes in the bilateral hilum and mediastinum with lung involvement. So close differential for lymphoma. To summarize, so FDG is integral in staging and response assessment in all FDG-avid lymphomas. So DVLA 5-point score as well as Lugano classification system are used to assess lymphoma avidity as well as the response visually and semi-quantitatively. And as shown in some slides, it can upstage as well as downstage the disease and can evade the need of bone marrow biopsy if there is a focal bone marrow uptake either in Hodgkin's or NHL. And it can identify richest transformation and guide site for biopsy. And these are my references. Thank you.
Yeah, thank you, Dr. Saikrishna. That was a very brief and elaborative presentation. Sir, over to you, sir. Dr. Nadeem Ahmed, sir. Any queries? I guess he has covered almost all the points of
Yes,
PETCT lymphoma.
sir has covered quite extensively. I wanted to know a few technical things. One is that usually, generally, whenever we refer for PET scans, they, if let's say patient is a chronic kidney disease patient and we cannot do contrast in him, so still is it better to do a full body non-contrast PET, sir, or can we just go ahead with CT scan? What
Yeah,
benefit, extra benefit will it give?
we can go for a non-contrast PET-CT, because PET
No, how
itself
is it?
functions as a contrast. It highlights if there is any active disease.
So
Obviously, it
FDG
highlights.
you can give irrespective of
Yeah.
creatinine.
Yes.
Yeah. Second thing is
If it has a very high background, it's like little we can give. In some cases, actually, we have seen after giving PET-CT in cases of like especially fibrous transformation, fibrous tissue residual disease, which is not taking any FDG uptake. So we need to correlate with CT. So that is only one concept.
yeah. Second thing is in Hodgkin's now recently what happens is for all non-Hodgkin's we should do bone marrow. But Hodgkin's, if there is no uptake and it is early stage, then we can avoid bone marrow. So now PET scan is becoming more and more important in Hodgkin's lymphoma because we can avoid bone marrow and then painful procedure for patient, which is much more comfortable. So this is one thing that is
I guess
very good.
Dr. Saikrishna has mentioned regarding this Lugano's classification where bone marrow biopsy can be avoided and in Hodgkin's lymphoma. Yes, I just conclude that regarding.
So I'll just show. Sir, in Hodgkin's lymphoma, if there is a focal bone marrow involvement, we need not do bone marrow biopsy anyway.
Yeah.
And there is a diffuse
Focal
uptake
we will
also.
not do it. What about diffuse? I'm
If
asking.
there is a diffuse uptake also, generally in limited stage disease involvement is less. So even if it is a diffuse uptake in advanced stage disease also, it is more common to be a non-pathological. That's why we leave. In Hodgkin's disease, we leave for a not necessarily going for a bone marrow biopsy. But if it is a diffuse uptake in NHL, because bone marrow involvement is more common in NHLs than HL, so if there is a diffuse uptake, still bone marrow biopsy is to be done. And if there is no uptake also, then in a certain case of DLBCL, there are some reports where even if no uptake, bone marrow has shown positivity. So
Okay.
with no FDG uptake also, bone marrow is still to be considered in DLBCLs especially.
Okay. Also,
And
discordant lymphomas. Yeah, you were saying
yes, sir.
something.
In indolent lymphomas, generally there will be low FDG bit. So if low
Also
FDG
in
ability
discordant,
is there,
I'm told discordant lymphomas, like bone marrow can show low grade, and then you get an excision biopsy that is showing high grade. So in that also, PET
yes,
scan will be very important to know.
yes, sir.
So two histologies that I mean.
Yes, sir.
As a imaging team, with a diagnostics, we don't follow up the patients in a regular basis.
Yeah.
What is the overall survival and progressive free survival in your clinical setting after PET
In Hod-
negative cases?
yeah, in Hodgkin's
Hodgkin.
though, Hodgkin's early stage favorable though it is more than 90%. Early stage favorable, unfavorable is around 80. Advanced
Okay.
Hodgkin's is slightly difficult to treat. Adults are easier. Children are slightly difficult. But the good thing that we should always remember in Hodgkin's is, even if it's patient has progressed beyond 2-3 lines, still there is possibility of cure with salvage chemotherapy followed by transplant. So yeah, very good only. We don't do follow up unless patient is symptomatic. We don't do PET scans annually, nothing like that. I don't think there is a recommendation for it.
No,
Yeah.
not
Yet.
recommended in survival.
Yeah, not required. People these days, they sometimes walk into the OP, they ask for a PET scan. I'm having
Yeah,
this
patients
pain
are
and
more aware of
yeah,
PET-CT as like.
yeah. Patient psychologically will be very satisfied with PET scans.
Yeah. Yeah, I guess this is a very brief,
Yeah.
elaborated talking to you, sir. And
Sure.
thank you, Dr. Saikrishna and Dr. Nadeem, sir. So, any other
Sure.
queries, or I'll close this session?
Sure. We can close. I'm looking forward to further meets.
Sure, sir,
Yes.
obviously. Thank you, sir.
Thank you.